I'm going to call upon Professor Yousuf Kamal. He will be talking about the researching cardiovascular events with weekly incretin-based therapies in diabetes, the Rewind study. Professor Yousuf Kamal is distinguished graduate of King Edward Medical College. After graduation, he did his postgraduate training and qualification both in UK and USA. He returned to Pakistan as the first medical director and clinical dean of AkU University Hospital, Karachi for 10 years, and then later CEO of Shaukat Khanam Cancer Hospital and Tabba Heart Institute in Karachi. He continued his practice with special interest in metabolic diseases, diabetes as a special subject. He is national and international faculty and known speaker. I would like to call upon Professor Yousuf Kamal.
Thank you, Zishan. Distinguished panelists, dear colleagues. First of all, I want to thank Eli Lilly and Bide for this opportunity to be talking before you. But my particular thanks really for the entire seminar are to Dr. Zahid Mia. I tell you, how many people would have done this to put everything together and discuss this seminar on complications of diabetes and foot diseases? Nowhere else. He's a pioneer, and please give him a big hand for this. What we are talking about and what we have heard so far is really complications. But if you had an opportunity to be a good doctor, would you prevent a disease? Would you treat a disease, or would you treat complications? I think that's the point we have to think. In all our statistics which are coming in, we are going to be the third highest in diabetes by the year 2045, having 65 million diabetics. We should hang our head in shame for this, not be proud of it. It is our fault that we have let the situation be to this extent. Always prevention is better than cure, always. Let's give me an example of burns. It is very expensive to treat burns, but you can design a chula which does not cause burn, majority of the causes. So the talk today, when I was discussing with Lily, that why are we talking today of this subject, Rewind study? The whole study is that when the last speaker, eminent speaker, spoke so beautifully about control of diabetes, he was emphasizing all the time glycemic control. With the present glycemic control which we have, if somebody comes with an HbA1c of 6.5, his fasting sugar is 116, his random sugar is 150, you are giving him statins, you are giving him Ascard, you are giving him Remipase, you are giving him Cerbex, you are giving him Sunny D, and all the still the macrovascular complications are 15%. Every 8 seconds, a person is dying of stroke, heart disease, or myocardial infarction and having heart failure. So where are we heading? Are we really giving the proper treatment? We have to move. We have to move from this glucocentric approach that glycemic control is important. Yes, glycemic control is important. It was important 10, 15 years ago, glycemic control. Then we came into another phase, that glycemic control with weight gain and prevention of hypoglycemia. We have to move away from this food. We have come to the stage now in 2-3 years. Glycemic control to hai hai. We have to prevent cardiovascular and renal complications. Any diabetic drug which we are using, if it is not safe and cannot prevent cardiac and renal complication, is not worth using. That is the extent. So how we can prevent all these complications you are facing right from the beginning, using those drugs which are not only safe but can prevent complications of diabetes. That is the message of the talk today. And a remarkable study was done, we call the Rewind study, just give you a glimpse of it. But the GLP-1s have changed the face of medicine and diabetes treatment. And wait, this is only GLP-1. The GIP-1s are coming, and this twinkatrin will change the face of diabetes management. We have to move away from glycemic control into the safety of the drug, as well as preventing cardiovascular and kidney disease. By using SGLT2s and GLP-1s, we have really upgraded the complication rate, in fact, reduced it by almost 30%. So the talk which I'm going to give you today is about GLP-1. Now, GLP-1s is a class of its own. It is a class effect. But there is also an effect of a product which depends on its molecule. Let me give you an example. The commonest drug which you use in hypertension is a combination of amlodipine with valsartan. Isn't it? Extor, Exforge, you name it, Ipsar, anything. But isn't it interesting that we are using one drug, which is amlodipine, which is a 24-hour action, and we are using valsartan, which has an 8-hour action. It's pharmacologically incorrect to use that. The only sartan which has a 24-hour action is telmisartan. You see, so we have to see the pharmacological side of it. Are we correct and all? So there is a class effect of ARBs, which is to reduce blood pressure. But there is a marked molecular effect, the affinity to the receptors, which gives it that effect of its own. And similarly, we have several GLPs now in the market. The Liraglutide was the first, semaglutide, and now daraglutide. They all have a class effect of GLP-1, but there's a unique effect of each one of them. Like liraglutide is very good for weight control. But the beauty of daraglutide is that besides being a once-a-week preparation, it has changed the face of medicine in the sense that this trial, Rewind, which has been done, has shown that it does not only reduce the secondary complication, but it also reduces the primary complications. So that's what we are talking about. Can we move this now? And we'll just now start this one. So that was the introduction, disclosures I have. This is a classic slide, always. Still the issue is, remember, that pre-diabetes and the diagnosis of diabetes, there are a lapse of 5 to 7 years. You know, I asked my students and some of the medical colleagues that when I was a medical student in King Edward, the level of sugar fasting was 136, then it came to 130, 126, then 110, then 100. Why 100? Anybody can answer? Anybody? Why 100? Why not 95? Yes, but how would you know? One of the beauties of King Edward were that my professors used to say that always ask questions till you are satisfied. It is at 100 milligram that you are able to detect retinopathy. At 100 milligram. And that's the reason. And so basically, diabetes, right from the pre-diabetic stage, is a cardiovascular disease, is a cardiovascular risk equivalent with micro and macrovascular. But the sugar is its marker. The disease is the microvascular and macrovascular. But the marker is sugar. That's the way we should look at it. And if we look at it that way, our treatment will be totally different. We will use those drugs which prevent micro and macro complications as well as sugar. And that is the purpose of this slide. We'll quickly go over. You see here, there's an armament of drugs which we can use. We have several drugs. And look at GLP-1 receptors. You remember the ominous octet. The ominous octet in diabetes, the organs, 8 organs. If you look at GLP-1, they cover almost 6 organs and they also cover kidneys. Because if you have an award 6 study or 7 study, you can see that it prevents and reduces macroalbuminuria. So it's one drug which can cover 7 of the octet figures. That is the beauty of the drug which we are using. Whereas look at insulin. Insulin normally covers 3. So the whole lecture of the point is that we have to use drug which is the maximum effect, not only on all the octet factors, but also in prevention of kidney and cardiac disease, cardiovascular disease. Unfortunately, we give much more importance to heart and brain, and nobody looks at the foot. It is Zahid Mian who started making us look at the foot. Otherwise, everybody is talking of stroke, myocardial infarction, and other things. Nobody mentions the foot. Yesterday, there was a very nice talk by Dr. Zaman Sheikh on prevention. He said, क्या करना चाहिए? अगर आप अपने पाँव को देखें, अगर खुद नहीं देख सकते तो बेगम को कहें कि आपके पाँव देखें. You know, that's the way to know the foot health. So when we are doing ECGs for our heart, we are doing cholesterol levels, we are doing MRIs for the brain function and carotid angiogram. Do we ever look at our feet? What is happening on our feet? The measurement of blood pressure in the arm and the feet is the first indication that something is going wrong. But we don't do it in our practice, do we? None of us do it. That's the first indication. So let's move on. That's the GLP-1 effect on all of these factors, on all of these. And it's a unique drug on that. Potential mechanism, why is it beneficial in cardiac disease? Body weight, visceral fat, LDL, albuminuria, blood pressure, atherosclerosis, cardiac ischemia, cardiac function. The whole process starts when apolipoproteins start accumulating under the endothelium. They attract monocytes. The monocytes become macrophages. The macrophages destroy the endothelium. The floating cholesterol deposits on them. The thrombotic fracture. That whole process is affected by GLP-1. And right from the beginning, as we'll show you in the study. Now, as I said, again, I have to mention Zahid. Zahid has changed our focus from this to this. But the process is the same. The atherosclerotic process is the same, whether it is in coronary vessels, in carotid vessels, but they become more prominent and we don't care about the feet. But the process is the same. The plaque stability, blood flow, smooth muscle, platelet aggregation, inflammation, endothelial function, all of this are modified by GLP-1. And in diabetes, the micro and macrovascular, again, I've highlighted them. But the limb amputation was never included in MACE. MACE only mentions 3 factors. I would like you that this should always be in your mind, that this seminar should create this awareness that peripheral artery disease is part of the same disease process. Type 2 management, as I told you, improve HbA1c was our first target. Then improve HbA1c without cardiac risk, weight gain, hypoglycemia. Then improve HbA1c. But look at the last thing. Improve patients' cardiovascular and renal outcome. This should be your objective in treating diabetes and not glycemic control. Please remember this. That's why the guidelines have changed completely. This is the guideline. Where is insulin? Can you see insulin in this? Is this incorrect? No. Insulin used to be the first. Now it is not the first. These are the drugs which are the first. That is the mindset change we have to make. Sulfonylureas are good drugs, but they have been kept here only because of the fact of availability and cheap prices. They reduce it, but they have very few cardiac benefits. As insulin has very few cardiac benefits. Therefore, the drugs right from the beginning which we have used are to be the drugs which have cardiovascular and renal benefits. Now, this is the trial which we are going to talk about, and there have been many trials. You know, people in diabetes are much more likely to have cardiovascular complications than non-diabetic. 4 times. Every 8 seconds, somebody is dying of myocardial infarct, is having heart failure, is having stroke. In spite of the good treatment I told you. So, A trial was done. Let's come to that. This is a real life trial. All the other trials of diabetic complications were related to secondary complications. That is the MACE, major cardiovascular events of myocardial infarction, heart failure, stroke, and death. But those were, they never considered the leg part of it, but leg part is part of the process. In real life, every diabetic does not have cardiovascular disease. He has cardiovascular risks, but does not have the disease. 68% have no cardiovascular disease. 32% had cardiovascular. In all the other trials of diabetes, 68 to 80% people already had cardiovascular disease. This is the major difference in this trial, the Rewind trial. So the idea was that let's look at the primary prevention, not only the secondary prevention, the primary prevention, and adjust the modifiable risk factors so as to prevent the onset of one thing. This is what I urge you to see. The important thing is to prevent the disease. Once it's established, there's very little you can do. Or we can do, of course, but at what expense and at what cost? So let's move on. So this is the Rewind study which was done. These are all the previous study, the leader, the sustain. Like I'll just mention so that all the people have been studying all along. And prior CVD was almost 80, 70, 80%. In this study, Rewind, people were taken who did not have cardiovascular disease. Only 30, if you look at it, in Rewind study, the ratio of the male to female population was equal. The number of patients was very large. The follow-up was very large, 5 to 0.4 years. In all the studies, it is only 2 years and 3. How can you follow a diabetic for 2 to 3 years? You need at least minimal of 5 years. And that's what gives credibility to this study. It was conducted in 24 countries on 6 continents, so that it is not biased in Europe or anywhere else. It was done in Asia, it was done in Europe, Australia, South America. And the retention rate was amazing. So many people with 5.4 year follow-up, they were almost retention rate of 97%, which is remarkable in a study. The key objectives of including people were they should be 50-year-old, they should have risk factors of cardiovascular disease, HbA1c should be 9.5, and they should already be on 2 treatment with basal insulin. And these were exclusions. And the primary outcome was the MACE. And this is the result, a remarkable result of study. The remarkable result was 12 to 13% decrease in primary outcomes and in secondary outcomes. No other study has shown. And that is really, we are very lucky that, you know, the 2 things which make a difference is in any treatment is availability and affordability. At least the drug is available. If you were a country like Afghanistan or Iran, none of these drugs are available. They are imported and they are not available. In Pakistan, at least we have started to have these drugs. We have the liraglutide, we have semaglutide, we have daraglutide. They are available at the moment. And if they are available, now one thing is there, we are a poor self-paying country. But if we want proper treatment, तो ये हमारा हक है कि हम फाइनेंस को खुद ना देखें. We have to give this option to the patient कि अगर आप ये ड्रग लगाएंगे तो ये आपको बेनिफिट्स होंगे. ये हम डिसाइड नहीं कर सकते कि ये आदमी अफोर्ड कर सकता है कि नहीं. Our job as doctors is to put the options before the patients कि ये ड्रग्स हैं, इनके ये साइड इफेक्ट हैं, उनके ये बेनिफिट है. अब आप चूज करें कि आपको क्या पसंद है. And that is a very important thing. But we don't make भाई नहीं इसको नहीं हमने ये ड्रग लिखना ये तो अफोर्ड ही नहीं कर सकेगा. We must give them an opportunity. So this was all these results along with HbA1c containment, that is the benefit. Weight control, which was another benefit. Systolic blood pressure was lowered, and heart rate was lowered. So the key takeaway, the Rewind, is majority of patients which were in this study did not have cardiovascular disease. statistically significant 12% reduction, and Trulicity or deraglutide is the first and only GB to demonstrate primary and secondary outcome. Adverse events were consistent with those of other drugs. The adverse events of any GLP-1 is nausea and vomiting, and which is to the extent of 7 to 10%, and after 2 doses, it withers off. And you also have to, the way you give it also is very important. So, once a week Trulicity, the advantage is it stimulates glucose-dependent insulin release. It affects glucagon, slows gastric emptying, and lowers these cardiovascular. This is really the complexity of diabetes in which this GLP-1 participates. The Rewind study were released in ADA, and this is a statement. To date, the level of evidence to support the use of GLP receptor agonists for primary prevention is strongest for duraglutide and lacking for other. That was really the message I wanted to give you, and now this is included in the guidelines. It's a very simple device. One dose, you cannot see the needle, very easy to administer, and that's the advantage. No change of pens is required. Once weekly gives the motivation rather than daily. So that was the message. The message is that in diabetes, prevention should always be in your mind, that it's a cardiovascular risk disease. We have to prevent and use drugs which have cardiovascular and renal benefits right from the very beginning. And that is the message today. If you have got that message, I think I would have done my job well. Thank you very much.